Hi everyone, this is Neel Raithatha, consultant audiologist and director of WAXscope. Thank you for joining me in a very interesting case which involves the WAXscope, which is only a few weeks now away from being launched. If you are interested in the WAXscope, please do feel free to email info@clearwax.co.uk and we can add you to our mailing list so you'll be alerted once it's ready and available to purchase and be trained in its use. So this patient, I actually treated their left ear first, so this is their right ear. And the reason why I'm showing you the right ear first is because they had a condition called benign osteonecrosis in this ear. Completely unbeknown to the patient and myself initially. In fact, they felt the left ear was the ear giving them more symptoms, hence why I treated that ear first. And now you'll see when you watch their left ear, just the colour and the consistency of this wax and keratin plug in this ear is completely different to their left side. And already at this early stage, I know something's slightly abnormal because I can feel that there's a trench here. You can see that what I'm trying to do is lift this plug of wax and keratin inferiorly from the base. I'm trying to lift it up and over. So I know there's a crater, you can see it there. You can see the spongy keratin and wax coming upwards and then kind of bouncing back down again and springing back down. So I know there's something going on the floor of the ear canal. What's going on there though? Is it initially, you always keep yourself open to the possibility that this patient's got a very rare ear canal cholesteatoma, which can be very dangerous and will require emergency ENT referral. So that's already on my mind. So fortunately though, this patient hasn't got an ear canal cholesteatoma, which is a formation of a dead skin cyst that accumulates in the ear canal. Cholesteatomas normally are present in the middle ear and they originate from a retraction typically of the eardrum. So the top part of the eardrum gets sucked inwards due to negative middle ear pressure, and skin that migrates off the eardrum, which should eventually then also line the ear canal until they continue to migrate out of the ear like a conveyor belt. As they migrate up the eardrum, the outer layer of eardrum is also made of the same skin that lines the ear canal. In fact, the skin that lines the ear canal, the site, the progenitor site where these skin cells are originally manifested, is from the center of the eardrum, the umbo region. And once formed and developed in the umbo region of the eardrum, the skin cells migrate radially. Think about a puddle and you drop a pebble in the center, you get these ripple effects. Imagine those ripples being dead skin, the epithelial skin, and it spreads outwards from the center of the eardrum radially, and it eventually coats the eardrum and the ear canal. But if part of your eardrum is retracted, sucked in, the skin cells, as they're migrating, they fall into the retraction pocket and they can't escape, and then they form into a cyst, and the cyst gets bigger and bigger, and it releases these enzymes which are digestive enzymes, so they're proteolytic lysosomal enzymes. And when they release these enzymes, they start chewing up all the surrounding tissue. So that could include the eardrum skin itself, the ossicles, the bones in the middle ear. It can then invade upwards towards the brain because the ears are just below the brain, the cranial cavity. So it's at the skull base. It can go. It can cause necrosis of the facial nerve, which runs in the middle ear. It can go posteriorly into the mastoid cavity, so it causes mastoiditis, a brain abscess, meningitis subsequently. It can go anteriorly towards to the jaw joint, the temporomandibular jaw joint, the TMJ, which is located to the front part of the ear canal. So that's your more typical canal, your middle ear cholesteatoma. Canal cholesteatoma actually originates within the ear canal, so it's a lot more rarer than the traditional form of a cholesteatoma. But this patient hasn't got that. Instead, they've got benign osteonecrosis, and there can be two difficult conditions to differentiate. So with a benign osteonecrosis is when you have an erosion, a widening of the floor of the ear canal, and it's of the bony portion of the ear canal. So the bone's missing, so the bone's broken away, it's decaying away, and that's due to reduced blood flow vascular supply to the inferior, so the floor of the ear canal, the bony part. And due to poor vascular supply, the bone doesn't have the blood and oxygen that it requires, so it basically dies, and you can then get separation of the bone, and we call that sequestrium. And when the bone begins to die, it creates a crater, a pothole, a well, if you like, and it sinks the ear canal in that region, and the skin lining the ear canal in that region also sinks. So that's your typical benign osteonecrosis. It can also happen secondary to radiotherapy, because if you have radiotherapy for malignancies of the ear or surrounding tissue, so the parotid glands, for example, it can damage the blood vessels supplying the blood to the ear canal. And sometimes even localized trauma. So if you're poking inside your ears using a cotton bud, you can cause trauma to the skin that lines the ear canal, reducing the blood flow, and then it develops into a benign osteonecrosis. A canal cholesteatoma is somewhat different in that the erosion of the bone is due to the formation of the dead skin cyst that is on the surface of the ear canal. So it's a top-down mechanism, whereas a benign osteonecrosis is a bottom-up mechanism. And with a canal cholesteatoma, you also get an ulceration of the skin. So the skin that lines the ear canal is no longer, it's infected. That can also happen with a benign osteonecrosis, but it's a lot more common with the canal cholesteatoma. And so when you've got the ulceration of the skin, the underlying bone is exposed, and when the underlying bone is exposed, this skin cyst continues to grow and it infects the bone. It causes it to die, so we call that necrosis. And also with a ear canal cholesteatoma, there's going to be active discharge that you're going to see that. So this patient didn't have that. So you see the crater in a minute at the floor of the ear canal. So I managed to remove that plug of wax and keratin. I used a combination of suction, the ear pick, and eventually the Rycorrect, which really helped. And if you continue to watch, I actually, after finishing the procedure, I just re-examined the ear using the endoscope just to make sure I didn't miss anything. With an endoscope, you do get a wide field of view, and I was really impressed by the fact that I managed to clear out this crater caused by benign osteonecrosis. It just occurs in one ear. Can happen in both, but it's more typically unilateral. It's more prevalent in the elderly population, and patients who take biphosphonates. So they're medication given to people who suffer from osteonecrosis, so osteoporosis, a weakening of the bone, which makes the bone fragile and easily breakable. Biphosphonates, I hope I pronounced that correctly. What they do is they inhibit the function of specialized cells that sit on the bone called osteoclasts. And osteoclasts, what they do, they're involved in what we call bony resorption. So osteoclasts on the sides of the bone, they break down the bone into its core minerals, and they retransport these minerals via the bloodstream to other parts of the body where new bone can be formed by specialist cells called osteoblasts. So bisphosphonates, I think it's pronounced with the S, they inhibit the function of the osteoclasts in an attempt to prevent patients who have got osteoporosis, so fragile bone, trying to prevent more bone loss, basically. But inadvertently, it can actually make the bone a bit more brittle, because it also can reduce the amount of calcium the bone has, and obviously we need the calcium in the bone to make the bone strong. So I think with patients who take bisphosphonates, they also have necrosis of the jaw, so that's quite common. So it is a listed risk factor of benign osteonecrosis in the ear if patients take bisphosphonates. So in this particular case, the skin is still intact. You'll see it once I can remove it all. So there's no ulceration, there's no sequestrium of the bone, there's no loose bone. The bone there's no fragments of bone for me to remove. In the case of a benign osteonecrosis, they normally typically occurs at the floor of the ear canal. So I suspect that region of the ear canals is more susceptible because it's already got reduced vascular supply compared to other parts of the ear canal. With the ear canal cholesteatoma, it can develop on any part of the ear canal. It's more common on the anterior canal wall, the front section of the ear canal, and the inferior canal wall. And that's because the migrating skin is slower when it migrates from the anterior canal wall and also the inferior canal wall. And remember, with an ear canal cholesteatoma, it's a skin cyst, a skin that lines the ear canal. If it stops shedding and migrating, should I say, laterally towards the entrance of the ear canal, it can form into a cyst. So it makes sense if there's a slowing down of the migration of skin, there's more likelihood of a skin cyst forming. In terms of treatment, this patient needs regular cleaning of their ears. Now they advised me that they used to have their ears irrigated every couple of years. Now, irrigation wouldn't remove that plug, so I'm hoping this patient obviously didn't have this condition when they last had their ears irrigated, because it would be an inappropriate method of removing this. And indeed, they may have not removed it, and hence why this blockage is quite severe. Surgery can be performed, and I think what ENT surgeons do, they try to revascularize this area. So they use the temporalis muscle to build up the area. So they kind of patch this area up, basically. If you have a pothole, and your local council will fill it with tarmac. So here you're filling it with a muscle graft, and then you're harvesting some periosteum, which is the sheath that it lines the bone. It should line the bone, and it supplies the bone with the blood, the nutrients, the nervous supply that it needs to sustain life. So they harvest some periosteum from other parts of the ear, and they reposition it on this area. So basically trying to revascularize it, give it more blood. And also apparently a hyperbaric oxygen chamber can also help, because of course that's going to supply more oxygen. And apparently a hyperbaric oxygen therapy can prevent the formation of gram-negative bacteria. So gram-negative bacteria are the more serious type of bacteria in the ear. They're more difficult to treat with antibiotics because they are encapsulated in a lipid structure. So antibiotics find it much more difficult to penetrate and kill or prevent the bacteria from reproducing, so it inhibits its reproduction rate. So that's another possible method of treatment. So when I'm removing this, I'm actually standing up and I'm angling downwards into the crater itself, and you just got a bit more keratinous debris here, so I just want to peel this away. I'm going to be very gentle because we are working on the bony part. Of course, this patient missing a lot of bone, but the bone that they do have, it is still sensitive. So I've just changed the focus, and I'm just going to re-enter. I'm using the fine end for this. So initially suction was performed with a standard Zollner size suction probe, but for more delicate work like this and the skin peels, I'm just using the fine end. It just gives you a bit more precision, a bit more control, it's less noisy. It works better with skin actually. So you can see here, this is like the cliff edge. So where I'm peeling this skin away, this is where the bony part of the ear canal is still present, and then you get this sudden cliff edge. So this skin is trying to migrate out of the ear, but it doesn't know where to go because there's no more bone in front of it. Instead, there's this ditch, this pothole. So that will eventually fall into that well, that crater, and form into a wax and keratin plug, which will really need removing on a regular basis. So I advise the patient to come back every 12 months. You've got a beautiful view of the eardrum. See all the blood vessels supplying the hammer bone. So I'm just having a good nosy around in there. Now this is the endoscopic view. So yeah, with an endoscope you get a much wider field of view, but I just want to make sure I've done a good job here, and I'm really pleased with that. So, and you're going to see a visual of, that's the plug of wax and keratin that I removed. And I'm going to flip it over, and you're going to see the underside. So you can see a bit more keratin there. So some of you may have seen the new RAI modified Bristol Ceremon chart based on the Bristol stool chart. Based on that, I would classify that as a type 5, I think. Type 5 type of wax plug. It's not fully smooth. It came out in a big piece. So we know it's got quite a lot of, it's probably got a bit more keratin content than lipid content. The more lipid content, the more oils and sweats you have in the wax, the more likely it is to come away in smaller pieces. A bit like in this ear, actually. This is probably a type 3 wax plug, so it's more lipids than dead skin. So earwax can be dry or wet, and the type of wax you have, it's down to a single genetic mutation, so a single nucleotide polymorphism, and that occurs on a gene called the ABCC11 gene, which is exclusively found on specialized sweat glands called apocrine glands. They're different to your normal ecrine sweat glands that are involved in thermal regulation. These apocrine glands are emotional sweat. They're produced in response to heightened levels of emotion, so fear, pain, stress, anxiety, and it produces this kind of odorous, it can be very odorous sweat. So this particular gene, it codes for a protein that transports additional molecules into the apocrine glands found in the ear called ceremonous glands. They're a specialized version of those. And if you have a functional ABCC11 gene, you'll get additional lipids being secreted, which then cause the earwax to be more wet because you've got a higher lipid concentration. And in addition, some of these additional lipids are odorous. They're either odorous immediately or once they're formed in the gland itself, or after they reach the surface of the ear canal, where they're degraded by bacteria that live on the surface, skin flora bacteria, more namely the corneum bacterium. So they degrade the oily sweat, and it releases volatile, pungent odor molecules. In this ear there's a higher lipid concentration, and we'll classify it as therefore being a type 3 wax plug, I think. Maybe even a type 4, which is probably an equal amount of dead skin and lipids, but definitely in their right ear is more of a keratin composition. There was still a lot of lipids in there, but more keratin. Hence, you actually saw that keratin on the flip side. When I turn the wax plug over, you'll see that sheath of keratin, that white layer of skin, and it made sense because when we're cleaning the ear, we're removing a lot of dead skin from that crater. So the left side, this impaction was more of a severe impaction in terms that it extended right from the entrance to the eardrum. In the right side, that plug of wax and keratin is more localized in the outer bony part of the ear canal. But here it's right up against the eardrum, and it's really compacted, and I've just put a lot of oil in here, just trying to loosen and change the consistency of this wax plug. So the speculum size I'm using is a 4.25 millimeter specular. I'm using this more and more. Initially with the WAXscope I was using the smaller speculi because it's got an opening at the roof, which is a necessity when you're using a device like this, because if the instrument to the suction probe went right through the center of the speculum, which would be the case if you don't have an opening, then your view would be obscured, and by the suction probe, the lenses be directly behind it, and you wouldn't really be able to see what you're doing, or what you are visualizing is very distorted and lacks clarity and definition. So you're having to have that slit at the roof of the speculum. So I'm inserting the instrument in that direction. But because that means the speculum is not fully formed, it kind of takes you a while to kind of get used to being able to use it in the same way as a normal speculum that doesn't have an opening. You just have to get your bearings a bit more. It sounds weird, but I think when people first use the WAXscope, they'll understand what I mean. So, and for that reason, I just actually preferred using the smaller speculum because the Z is just a bit more straightforward, inserting it into the ear, and actually even with the smaller speculum, it was still enough space inside for me to work and operate the instrument. But I'm generally using the bigger speculum now. We have got a larger size, 5mm for large ear canals, and we've got an extra large one for patients who have got very abnormally large ear canals, and that's typically post-surgical. So if the patient's had a mastoidectomy, so the mastoid bone is drilled away, I should call it a canal wall down mastoidectomy. So the mastoid bone is the bone behind your ear. You can actually feel part of it if you just place your finger behind your auricle, your pinna, which is the flap of cartilage on the side of your head. You can feel the flat surface. That's the mastoid bone. That's an air-filled bone. It's got honeycomb structure, and it's susceptible of getting infected from middle ear infections or cholesteatoma. And if it does get infected, it's called mastoiditis. You can get inflammation of the mastoid bone. It becomes very red and painful. And if that doesn't clear with medication, naturally then that mastoid bone, the infection can spread upwards towards the brain. It can lead to meningitis, brain abscess, and possibly even death. So it can be very dangerous. So if the infection doesn't clear, an ENT surgeon has no option but to drill away that mastoid bone. And when they drill away, especially in the case of a cholesteatoma, if you've got a cholesteatoma forming, just to make sure the cholesteatoma is fully removed, because if it's not fully removed, this cholesteatoma has got the potential of regrowing itself. They generally can drill into the ear canal as well. So they make a widened ear canal. They merge the mastoid bone with the ear canal. So you just get much better visualization. You can ensure any traces of cholesteatoma is removed. So patients with a canal wall down mastoidectomy, they have a much enlarged ear canal, so the 5.75mm specular, the extra large, will be useful in those patients. So you can see this wax is quite dark, so it's been there for a while. It's oxidized. I think with the WAXscope, you get a real appreciation for the composition of the wax plug. You can probably see some of the individual skin cells there. They're being reflective. Then you've got the hair, which is another dry matter that forms earwax. And the dead skin cells and the hairs form the framework. It's almost like a bricks and mortar structure and composition. You've got the dry matter providing the scaffolding, so your bricks, and then the mortar, which is all the lipid contents of the sebum and the oily sweat produced by the modified ceremonous glands that I described earlier. They bind the dry matter together and collectively they amalgamate to form a wax plug. So the WAXscope gives you a good appreciation of that. So I've just further dosed the ear to put loads of oil in. So what do I prefer, the WAXscope and the endoscope? I think with an endoscope, it provides an unrivaled field of view. So in terms of pure optics, the WAXscope is very magnified, so it's a different type of optics. I'm actually beginning to enjoy the WAXscope more and more now, especially in cases like this in the first ear where the speculum does help to stabilize the visuals, so you can concentrate more on the removal of the dead skin. With an endoscope, you're continuously having to hold the endoscope and make sure, and that's normally held in your non-dominant hand as well, and quite often it's not supported when you're holding it, so you're holding it in mid-air, suspended in the ear canal. Sometimes you can rest it against the ear canal wall. It depends on the type of procedure and whereabouts of the wax is in the ear canal. But when you've got the speculum, it really does stabilize things. So for that reason, they've both got their pros and cons. I think ultimately, the endoscope is unrivaled, but I think the WAXscope, for me, and it's very biased because obviously I've developed it, it's the next best alternative, I think, in terms of optics. For the use of earwax removal, you've got an ENT microscope which provides very magnified view of the eardrum. but it can be more difficult for people to learn to use a microscope. I just had that discussion with an ENT consultant today who's trialling the WAXscope, and they mentioned that it's going to be a lot easier to use the WAXscope than an ENT microscope or an endoscope. So using an endoscope and an ENT operating microscope do require a high skill level, so it can be difficult. So managed to remove that plug. We're going to get a good visual of the eardrum now. So just adjusting the focus. I mean, you can see those individual blood capillaries supplying the hammer bone. Slightly dilated because the wax impaction is up against the eardrum. There's just a bit of wet wax around the edge. And we're just going to leave that in there. It's not going to cause the patient any harm. And you're going to see both plugs of wax there side by side. So in the left ear, the second ear, it came out in a smaller piece. You couldn't, because a lot of it got suctioned up, the suction probe. But there was a lot more wax in there actually than it's visible on the tissue. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.